To place fluoride varnish, first open the package. These come in all shapes and sizes, but generally they all come with some sort of application brush and the fluoride itself. Make sure you get any extra varnish off the top because a lot of times it separates, so you'll need to make sure that you have a good and even mixture. When using varnish, make sure that you read the instructions for each brand because some say that you have to dry the teeth and some say that it's not necessary. I'm going to demonstrate how to dry off the teeth if the brand does recommend that. And there are two ways. You could use the air water syringe or the 2x2 gauze. If you keep your fingers somewhere in the mouth, the patient won't close and re-wet everything that you've just dried. Apply a small amount of varnish on your brush and then start near the margin and brush down in 3 strokes. If your patient has a lot of recession or sensitivity, you can also do a little rainbow stripe across the margin like so. Make sure as well that you have a fulcrum so that you have stability to avoid getting the varnish on the patient's lip because the patients don't like the sticky feeling. Also, if you bend the end of the brush at the neck, it will make applying the varnish on the posterior teeth much easier. When billing this code, you want to use Da107, which is topical application of fluoride varnish. Have the patient close slowly, and the patient's saliva will help the varnish harden to the teeth. Also remember to give and document the fluoride post-op instructions to your patient, which are, you can eat and drink right after application. There should be no brushing or flossing for 4 to 6 hours, and also avoid hot, crunchy, or sticky foods for 4 to 6 hours.
The first step is to apply 35% phosphoric acid inside the tooth, starting with the enamel and then the dentin. If you have air bubbles, you want to remove them so that you have all the acid in contact with the tooth. Notice that I've applied the etchant beyond my cable surface margin, and you want to do that to make sure that your bonding agent is going to bond to an area that the acid etchant has been in contact to. You want to leave the acid for 15 seconds, and then you want to rinse for 20 seconds. You want to then air dry for 3 seconds and leave the surface slightly moist.
As a permanent luting cement. The thing with zinc phosphate that we have to remember is that it is exothermic, which means that it does release heat. So we want to mix it on a cool glass slab to absorb some of the heat produced. To dispense the powder, fill the cap to the shoulder and dispense onto the glass slab. For the liquid, we want to dispense 6 even drops. If we need more material, we can always double this ratio. So as nearly as possible, we want to form a rectangle with our powder, and then first divide it into quarters, and then one of these quarters is divided into 2/8, and then the 1/8 is divided into 2/16. Each increment is timed as we mix the powder into the liquid. We start with our smallest increment and we're going to mix that for 15 seconds. We always want to use a broad figure-8 stroke, nice and slow to dissipate the heat, and using quite a large surface area, which will also help dissipate the heat. The second increment is mixed for 15 seconds as well. And now we're incorporating our 8th for 15 seconds. The quarter is then incorporated and mixed in the same technique for 20 seconds. And then next quarter is mixed for another 20 seconds. And finally, the last quarter is incorporated for 35 seconds. Mixed in this manner, our material will be a luting consistency, which will allow for the accurate placement of an inlay or a crown, no matter how precisely fitted the crown or inlay is.
Mixing glass ionomer cement for permanent luting. Read the manufacturer's directions and fluff the powder in the closed bottle. Fill the measuring scoop without packing and level against the plastic lip in the neck of the bottle or with the cement spatula to remove excess. The amount of powder needed is determined by the amount of cement needed for the procedure and by the manufacturer recommendations. Place the powder on the right side of the pad. Replace the cap on the powder bottle. Holding the dropper or liquid bottle perpendicular to the pad, dispense the recommended amount of liquid close to the powder without touching. Replace the cap on the liquid immediately to prevent evaporation. Using the cement spatula, add the powder to the liquid in one portion. Incorporate the powder into the liquid and mix well using a figure-8 motion. Complete the mixing within 60 seconds. Once the mixing is complete, gather all the material into one area. For luting, the mix should be creamy, and as the spatula is lifted off the pad, the cement should follow the spatula for about 1/2 inch before breaking into a thin thread.
I will demonstrate the mixing of zinc oxide eugenol cement to a secondary or sedative restoration consistency. Zinc oxide eugenol is used as a temporary restoration when the pulp is inflamed, as the eugenol has an obtundant effect on the pulp. Fluff the zinc oxide powder to aerate the contents and place 3 scoops on the pad. Place 1 extra scoop in a corner to be used if needed. Shake the liquid bottle and dispense 4 drops of liquid on the mixing pad. Make sure the powder and the liquid do not touch. To mix, incorporate half of the powder into the liquid and flatten firmly with the spatula. Apply heavy pressure to incorporate the powder. Incorporate some of the second half of the powder. Adding the powder quickly in 2 increments will make for a stronger mix. The cement is the correct consistency when it can be rolled into a ball or roll. Check with your fingers that it is not tacky. Roll cement into a rope with your fingers or the spatula and break into smaller pieces. Each piece will be carried to the cavity preparation. Using a condenser, carry 1 small piece to the cavity preparation. Pack the cement into place with the condenser. If the cement sticks to the condenser, dip the end in the powder. Continue adding increments of cement and condensing until the entire cavity is filled. Smear the cement against the cavo surface margin to create a seal. Using amalgam carvers, create anatomy in the cement. This video will demonstrate taking alginate impressions on a patient. Please review the previous video and the lab manual for the correct technique of mixing alginate impression material. There are two tray types that can be used to take an impression: disposable plastic trays and metal trays that can be sterilized. Impression trays come in small, medium, and large sizes. If the tray needs to extend distally, it may be built up with beading wax. Metal trays have a rim lock edge and many perforations that prevent the alginate from separating from the tray when removing it from the patient's mouth. Since these trays are sterilized after use, adhesive is never used on these trays because the adhesive cannot be cleaned off. Disposable trays must sometimes be coated with adhesive to prevent the alginate from separating from the tray. This is especially true for trays with few perforations. Prepare the materials you will need with clean hands. Tumble the closed alginate canister. Fill a scoop and tap firmly until the powder is condensed in the scoop. Scrape off the top of the scoop with the spatula. Measure out 2 scoops into 1 dry bowl for the mandibular impression. Measure out 3 scoops into another dry bowl for the maxillary impression. Replace the canister lid to avoid contamination of the alginate with water. The water measures are ready with room temperature water. Warm water will accelerate the set of the alginate and cold water will retard it. Estimate the size of the trays that will be needed and size the trays in the patient's mouth. A barrier must be used on the disposable tray so that it will not be contaminated. Metal trays can be sterilized, so they do not need a barrier. These directions are for the right-handed clinician. Left-handed clinicians will reverse the directions. To check the fit of the mandibular tray, the clinician stands at 8 o'clock. Hold the handle of the tray with your right hand and turn it over. Retract the right cheek with the index finger of your left hand. Hold the tray sideways and insert, using the side of the tray to retract the left cheek. Rotate the tray into the mouth until it is centered. For mandibular trays, lift the front of the tray up and visually inspect that the alveolar ridges clear the tray. Ask the patient if the tray feels comfortable. To check the fit of the maxillary tray, the clinician stands at 8 o'clock. The insertion of the tray is the same as for the mandibular tray. When the maxillary tray is in the mouth, lower the front of the tray to make sure it clears the alveolar ridge. Ask the patient if the tray feels comfortable. Ask the patient to rinse with full-strength antimicrobial mouthwash for 30 seconds. Gently stir the water into the powder until the mixture is completely wetted. Then spatulate vigorously against the sides of the bowl to prevent air bubbles. Fast-set alginate requires 45 seconds of mixing for a creamy consistency. Gather the alginate onto the spatula and load the mandibular tray from both sides. Use a wet finger to smooth the surface of the alginate before taking an impression. You are now ready to take the mandibular impression. The right-handed clinician stands in the 8 o'clock position facing the patient to take a mandibular impression. The chair is raised so the clinician does not have to bend, and the patient is seated upright. Hold the tray handle with your right hand and turn it over. Retract the right cheek and hold the tray sideways and insert, rotating the tray into the mouth until it is centered. Seat the tray gently over the teeth and tissues from posterior to anterior. Immediately muscle trim the impression by bringing the patient's lower lip up over the tray edge. Instruct the patient to lift their tongue and relax it. Hold the tray into the patient's mouth until the alginate feels rubbery and does not stick to your fingers. The set time of alginate using room temperature water is 2 minutes and 30 seconds from the start of the mix. Once the material has set, break the seal with one finger in the left vestibule of the patient's oral cavity. Snap the tray out quickly to minimize distortion. Remove the tray by rotating it out of the oral cavity. Ask the patient to rinse out excess alginate. Rinse the impression under running water. Spray with disinfectant, but do not soak an alginate impression in liquid disinfectant due to the likelihood of imbibition. Wrap in a paper towel that has been wetted and let sit in a bag to maintain 100% humidity. For the maxillary impression, the right-handed clinician stands at either 11 o'clock or 12 o'clock. The chair may be lowered slightly to have a better view over the patient's head. Remind the patient that they will breathe through their nose during the impression. For the maxillary alginate impression, add 3 measures of water to 3 scoops of alginate powder. Spatulate vigorously against the sides of the bowl to prevent air bubbles. Load the maxillary tray from the posterior. Use a wet finger to smooth the surface of the tray, and you are now ready to take the maxillary impression. Standing at 11 o'clock, retract the patient's left cheek with your left index finger. Holding the tray sideways, use an edge of the tray to retract the patient's right cheek. Insert the tray and rotate it to center it in the mouth. Align the handle with the midline of the central anterior teeth. Seat the posterior of the tray first and lift the handle to seat the anterior. Muscle trim the patient's upper lip around the tray rim. It helps to hold the patient's head upright with your left arm behind. This prevents the patient from tipping their head back and helps to prevent gagging. Hold the seated tray until the alginate feels rubbery. To remove the impression, stand at 8 o'clock in front of the patient and break the seal in one of 2 ways. First, have the patient close their lips and blow to puff out their cheeks. If that does not release the seal, bring your right index finger along the left edge of the tray and break the seal manually. Snap the tray out quickly to minimize distortion. Use a finger of the left hand to create a cushion over the opposing teeth so the tray does not snap against their mandibular teeth. Remove the tray by rotating it sideways. Instruct the patient to rinse out excess alginate. Provide the patient with a wet towel and mirror to wipe excess alginate off the skin. Rinse the impression under running water and spray with disinfectant. After 10 minutes in contact with the disinfectant, rinse the impression before pouring it in stone. It is recommended to pour the impression as soon as possible, as distortion increases due to delay in pouring and evaporation.
All right, we have two different impressions here of the exact same lower mandibular arch that I'm going to do a contrasting comparison with one impression where the alginate was too runny and another one where it was the perfect consistency. First of all, let's view the very front of the tray. You can see here on this one where the material was too runny, you can actually see some of the actual holes, the retention holes that are still visible. The material, the alginate, was actually pushed out of the way by the mouth muscles because the alginate was too runny. You can see a hole here, here, and here, and you can see that the tray is still showing through. I'll highlight it here with this pencil. On this impression, you can see that there is a small portion of the tray that's showing through, but the majority of it is covered up, and you can see there's a large rounded type of border as opposed to this sharp contrasting border right here. Let's hold this up and show you. You see how thin this is? This is thin because the alginate was thin and the muscles were pushing the material out of the way. I can move that with the end of the pencil there. You can see how thin it is. As opposed to this, to where it is larger, thicker, and more rounded. It's not just, it doesn't come to a point. If we also observe on the very back in the retromolar pad area or the back of the mouth, you can see these here are very thin, very flimsy, because again the material was wet and the muscles were pushing the material out of the way. Whereas on this, they are thicker, they hold their shape, and there's a much more rounded vestibule all the way through the mucobuccal fold as well as on the inside, on the lingual. So in comparing and contrasting both of them, you can see the difference. You can also see how the tray back here on this one is actually showing through. And you can see the borders of the stock tray, whereas with this one, it's not as visible and it's a little more defined on the borders. Let's flip it over and see what the difference is between a runny and a perfect consistency. On the runny side, you'll be able to see that not all the material, even though the tray was seated, not all the material made its way or was pushed up through the retention holes. Here on the very back portion, you can actually see it's almost a concave type of hole right here, as opposed to the holes that are here where most all of the material is pushing through, just like those typical Play-Doh models that you use where you put the Play-Doh in, squish down, and the hair comes out. You can see how much more defined these ones are than these, and how they're coming through almost all of the holes as opposed to the runny model where it's only coming through the front. And so please make sure that when you do seat the material, that if you're not getting all of the material to push through those retention holes, then you probably have a mix that's too runny. Looking on the sides, you can see how well defined those borders are and how it's coming up and over and around the tray. The lip line is right here, whereas on this one, comparing both side to side, you can see the material is kind of flimsy and just all over the place. There's no really well-defined borders here as opposed to here. And last of all is the ability of, if you have a wet mix, that the material pulls away. Can you see how I can put a little bit of pressure on this and pull that front section right next to that labial freedom away with just a little bit of pressure because the material was running. Same thing back here on the flanges of the tray. Just a little bit of pressure pulls that away, which is cause for distortion, whereas here I can apply a lot of pressure and nothing pulls away. Same thing with here. Because the material has gone around the borders of the tray and is stiff and holding to itself, you don't get that flimsy reaction like you do here as opposed to here. Okay? So those are comparing one that was flimsy and one that was
The capital is the upper portion of the maxillary cast. The base is the lower portion, the part that's resting flat on the table. The art portion is the non-anatomical portion of both the upper and lower casts. The heel is the portion between the side and the back of each cast. The side area is the flattened area on the side of each cast, and the arc is the circular area on the lower cast. Before we begin, I'd like to show you a set of properly trimmed models so that you can see what we're trying to achieve. The capital and base are parallel to the floor. The total height is 2 1/4 to 2 3/4 inches. When in occlusion, the backs of the upper and lower casts are in the same plane. The art portion of each cast is symmetrical, thus reflecting any asymmetry in the occlusion. The periphery of each cast is approximately equidistant from the facial surfaces of the teeth, and it is trimmed to the depth of the vestibule. All vertical line angles are parallel and perpendicular to the base. The heels are from 3/8 to 5/8 of an inch wide. They are equal from right to left, but not necessarily equal from upper to lower cast.
The alginate impression is a negative replica of the patient's dentition. The impression must be poured up with a durable product to create a positive replica. We use dental stone or plaster to make a model that can be used for study models or lab work. I will demonstrate mixing dental stone and pouring a maxillary and mandibular impression without a stone base. These models can then be used to make bleaching trays or athletic mouth guards. The correct ratio of dental stone to powder is 100 grams of stone to 30 to 34 milliliters of water. 34 milliliters of water is added to a rubber bowl. 100 grams of the powder is added until the particles become wet. Gently stir all the powder into the water to minimize the amount of air trapped in the mix. Vigorously mix by wiping the spatula against the sides of the bowl to incorporate all the powder and remove excess air. This is called stropping. Mixture should be smooth and homogeneous. Turn the vibrator on low and place the bowl on the work surface. Covering the vibrator with a plastic bag will make for easier cleanup. Press the bowl downwards onto the vibrator and press the sides of the bowl inward with your hands. This will remove all air incorporated during the mixing procedure. Holding the handle of the impression tray, place the tray onto the surface of the vibrator. Angle the tray with one posterior edge touching the vibrator. Pick up a pea-sized increment of stone on the end of a small spatula. Allow the stone to flow into the tooth indentations. Tilt the impression as needed to aid the speed of the flow. Continue adding small increments of stone to the most posterior end of the tray, allowing it to flow anteriorly. Air bubbles will form if the mixture flows too quickly over the tooth indentations. Tilt the impression toward the opposite posterior end and continue adding stone until the flow reaches the other end of the impression. When all the tooth indentations are filled with stone, lift off the vibrator and begin adding larger amounts of stone until the impression is filled to the top. Vibrate the entire tray for 2 to 3 seconds to settle the material. Place the impression on a tile with the tray edge towards the tile. Stone must set for 45 minutes before unmolding. After the stone cools, it begins to absorb water from the alginate and the final strength of the stone will be compromised. Stone that has been left in the alginate too long will have a chalky surface and be prone to breakage. Remove stone model after cool to the touch, at least 45 minutes after pouring. Before removing stone from the alginate, take a lab knife and clean excess stone from tray. Unmold impression carefully to avoid breakage. Inspect incisal and occlusal edges for voids and excess blebs of stone. Air bubbles incorporated into the stone during pouring will result in voids in the final stone model. Remove blebs of stone with the lab knife. I will demonstrate making a stone base for the poured impression. The stone base is also called the art portion, since it will be trimmed to specific guidelines. To make the base, you can make a fresh mix of dental stone using less water to create a drier mix. You can also mix extra stone during the original pouring of the impression. The extra stone will be used to make the base. The poured impression can sit for up to 10 minutes before the base is added. Take excess stone from the bowl with the spatula and place on a dry paper towel. Remove excess water with the paper towel until the stone patty holds its shape. Form the stone into a rounded triangular shape on the tile. The base must be at least 1/2 inch thick and slightly larger than the dimension of the filled impression tray. Invert the impression onto the stone base, matching the rounded edges. Make sure the occlusal plane remains parallel with the tile. Gently move the impression back and forth to bring together with the art portion. Use the spatula to join the stone of the base with the poured impression. Be careful not to bring stone up onto the impression tray, or removal of the set impression will be difficult. If the base is too thin and runny, use wet paper towels to wrap around the perimeter of the base to hold it in place. Remove these before the stone is fully set. Allow the stone to set 1 hour before separation from the impression. Model must be cool to the touch. Failure to separate the impression from the stone cast after 1 hour will result in a lack of surface hardness and chalkiness of the stone. For mandibular impressions, fill the tongue area with wet paper towel before inverting. Remember to remove the paper towel when the base is slightly set and use the spatula to smooth the tongue area. This prevents a large mass of stone from filling the tongue area.
Start with an adequately poured cast that is sharp and smooth and thick enough for total height. Small bubbles can be removed with a No. 7 spatula prior to trimming. If you soak the casts in water for 5 to 15 minutes, they will be easier to trim. However, make sure that you don't place them under running water or soak them for a prolonged period of time. This will cause a great deal of surface roughness. Now we'll move to the model trimmer, and I'll show you how to actually trim your models. Before you begin any trimming, make sure that the table of your model trimmer is perpendicular to your cutting blade. When trimming, you should begin with the upper cast. You may have to trim down the sides a little bit so that it can fit inside the model trimmer. The first cut that you make on your cast is the most important one. And this is the cut where you trim the capital. You should trim it so that the plane is from 0 to 5 degrees to the occlusal plane. This is to compensate for the curve of speed. After your capital is trimmed, you should establish the midline. You can mark it with a pencil and follow right along the midline suture. Don't use the space between the two centrals as a reference point for your midline, because this very often may be off center. Now you will trim the back of your cast so that it is perpendicular to your midline. If you keep the capital flat on the table of the model trimmer, the back will be 90 degrees to your capital. Make sure in doing this step that you don't trim in too far. When the back is trimmed, you can then trim the sides. I prepared a cast here to show you what we're aiming for in the sides. You want your cut to be parallel to an imaginary line drawn from the cuspid through the central fosses of your posterior teeth. The opposite side should be even with your initial cut. You use an angle former to check these measurements. It will make it a lot easier for you to get these areas even. If you don't have an angle former, you can get the sides even by transferring the midline onto the surface of your capital. Draw two parallel lines perpendicular to your midline. Measure equal distances along the parallel lines to the opposite side, and draw a line through these distances. Now you can cut away your capital until it is even with this line. With a little more experience, you can cut these sides by just using eye judgment. After your sides are trimmed, you'll trim the front portion of the model. You should trim from an imaginary line opposite the center of your cuspid to the midline on the most normal side of the cast. After you have your fronts trimmed, you may trim the heels. The heel should be perpendicular to a line drawn bisecting the angle opposite the heel. A good way to get these heels centered is to place your thumbs right on the angle opposite your cuspid. upper. It's symmetrical with all angles equal, and the back is perpendicular to your capital surface. To trim the lower cast, you should relate the upper and lower cast together. A wax bite is very helpful in doing this. The first cut on the mandibular cast is to make the back surface parallel and on the same plane to the back surface of the maxillary cast. The easiest way to do this is place the capital flat on the table of your model trimmer. Place the teeth in occlusion and trim until the backs are even. You can check this by setting your models in occlusion on their backs. After you have the backs trimmed evenly, you should trim the base of your model. Set the back of the mandibular cast flat on the table of the model trimmer. And trim the base. Make sure that you keep the back of the model flat on the table, and this will ensure that your cut on the base will be perpendicular to the back. The next step is to trim the sides. You will do this in the same manner as you trim the sides of the maxillary cast. You'll notice that I've trimmed down a little bit the sides of the cast so that it would fit in the model trimmer. I have a pre-trimmed cast here to show you how the completed trim of the sides should look. After the sides are trimmed, you should trim the arc. The arc should be a concentric circle, a semicircle concentric to a circle that would be drawn through the facial surfaces of your anterior teeth. After the arc is trimmed, you should trim the heels. Unlike the maxillary cast, the mandibular heels should be trimmed so that they are parallel to the opposite side. When the mandibular cast is trimmed down, you should relate it to the maxillary cast. Resting the cast on the back. If the backs are not perfectly equal, you may have to trim a little bit more to even them up. Now that our models are all trimmed, I'd like to say a few words about finishing the models. While they're still wet, fill in any voids with a mixture of plaster about the thickness of heavy cream. When the plaster is fully set, smooth all the flat surfaces using a large Arkansas stone or sandpaper. When using the sandpaper, make sure that you place it flat on the table and rub the flat surfaces of your model along the sandpaper. This will help ensure that you keep your angle sharp. You can use a number 7 spatula to remove any imperfections as bubbles along the gingival borders. The tongue space should be cleaned out using a rotating stone or a lab knife. Allow your models to dry for 1 to 2 days, and then label the models with a sharp pencil. You should print in capital letters 1/8 of an inch tall. On the first line, put your patient's name, and on the second line, the age in years and months, and the date that the impressions were taken. On the lower model, just put the patient's name.